Assalamu alaikum. Welcome everyone on board. Um, we will continue our uh, plan of having a look on the main anesthesia topics, which are pearl of our anesthesia care. Okay. Um, if before I start, anyone has got any question about the previous discussions or anything? Any question? Just give me a Oh, sorry for the interruption. Um, you can say that airway management is the part of parcel of any anesthesia care. Okay, so like there are so many misunderstandings in different people about what is difficult airway, what is difficult mask ventilation, how to uh, manage different problems related to anesthesia care with reference to airway. Okay, am I audible? Like my voice is clear?
Yes,
Yes,
sir.
Okay. So actually, just remember one thing that difficult airway is combination of either difficult mask ventilation or difficult laryngoscopy or difficult intubation. And actually, these are three different things. Sometimes some patients are difficult to have mask ventilation. The example for such cases will be obese patients with big jaw, especially to be handled by a female anesthetist with small hands. So that will become a very difficult mask ventilation. But if you make the proper anticipation, maybe you will find that the intubation is very easy. Okay. So you just have to, because even practically, you have to identify and then you have to respond accordingly. Okay. So that's why they're the like in the exam they will ask you the specific definitions with reference to DAS guidelines. Okay, so you can get the exact definition of difficult intubation or difficult airway exactly word to word by that one. Let me tell you the because you will not see such document which I opened because before taking these classes, what I used to do, I used to make questions. Okay. So, I used to make questions and just share them with everyone. So, I will just show you the history of this thing and that you will find here in the main my link, Google Drive link, this document. Okay. So I before when I did don't used to take these classes, I used to dissect, or you can say post-mortem of the questions. Okay. So then I used to request, because then when you what used to be the question, sir, where are the answers? So actually people even don't want to find the answer. They don't want to search the answer. So you will still, there are a number of questions which I made at that time. Still you can access them, but after actually when I started taking the Zoom classes, unfortunately I couldn't make more questions, but you can see a lot of questions are here. Then I used to request junior residents to try to find the answers, and I will tell you the source and try to compile. But can you believe this, that only I found one person who just made one set of questions, and actually this is the document which was sent to me by Dr. Madhiya Bas once upon a time. Okay. So anyways, these questions are there, and I will suggest you, I will quote you the statement of one of my teacher, which you can say that like when I started anesthesia, he was one of the figure everyone used to idolize him. Okay, his name was Sajid Usman Kaul, and you can say. that he was a legend, and I will quote his word, that if you want to know that you know the subject, then try to make question out of it. Okay, if you want to know that whether you know the subject, try to make a question. Or other word, you can say, if you read a page of a book, and now you want to think, see whether you know the subject correctly or not, try to make a question out of it. Okay, so that's what actually I was following. I was just try to see the all the aspects of that topic, and then try to compile them. And of course, if, for example, I'm not preparing for any exam no anymore, so it was very difficult for me to find the answers as well, but every answer will be there. So that is a few second history about this document. So we will just try to have a look at it. It's available in the Google Drive. You can follow it. So like either it will be difficult ventilation or difficult intubation. So if I ask you something which is more serious, whether difficult intubation or difficult mask ventilation, which is more serious?
So
Sir,
difficult
difficult
ventilation.
ventilation,
Difficult
sir.
ventilation.
Very good. Okay. Because if you are able to ventilate, even in a case in which you are not able to intubate, there are so many things which you can do, and you can awake the patient. Okay. But if you are hanging up in a patient whom you are not able to ventilate, and then following, you are not able to even intubate, then it's a disaster. It's a nightmare. Okay. So actually, this is something you should be knowing about it. I will try to, because we have limited time, I will try to give a basic concept, and then you can read the more details. So I give you a scenario, for example, because I will start in a slightly different way. If you are not able to intubate and ventilate, so what are the problems? And usually, practically, even in the exam, usually they give the scenario of a big and large thyroid. Okay, so in that scenario, what will you do? Please raise a hand, and I will, because if two people will speak, nobody will be able to answer. Okay, so anyone who wants to speak out, I will repeat my question, that you have a difficult intubation scenario in which you even are not able to ventilate, and I'm giving you example that it is a large neck swelling thyroid. Yes, Dr. Noman, please. What will you do?
Sir, we will assess the airway at that time, and if we have adjuvant, sir, adjuvant, sir, devices, we can use that to ventilate the patient, because ventilation is important. We have to maintain the airway. So
Okay.
because if we have given, yeah, sir.
No, like increase the scenario. Like you are not able to have mass ventilation, and now you try to put IGEL or LMA, and you are not able to still ventilate. What will you do now?
Wake up the patient.
Wake up the patient. But till the time you are able to, you had given like patient is in apnea, and how will you awaken the patient? Yes, your answer is good. Yes, please. Mudassira, you answered the question, please. Who answered the question?
Yes, I did. I did.
Yes, yes. What will you do? What are different options to awaken the patient? If you have given rocuronium, you can reverse with Sugammadex. Okay, this is
Yes.
one option. But what else? If you have not given any muscle relaxant, then what will you do?
Sir, we can keep the patient in sir, recovery position, and also, sir, we can use the jaw
No, no.
thrust and
I'm
chin
sorry.
lift
I'm
maneuver.
sorry. I'm sorry. You are not picking my question actually. Thing is that I will write it just to make better. Just a second. You are not able to ventilate. You are not able to intubate. Okay. You are not able to pass the IGEL or LMA. Okay. And you have limited time. You have already wasted maybe 2 to 3 minutes already. Patient is getting blue. What does the
Sir,
DAS guidelines say about it?
sir, uh, uh, percutaneous cricothyroidectomy
Front
or
of neck access. Okay. So it
yes,
is
sir.
the front of accessness. But here the problem is that there is a big and large thyroid swelling. There is no place, you are not able to identify anything. What will you do now?
Sir, jet ventilation.
Jet ventilation, correct your concept. For just jet ventilation, you need intact airway.
Yes, sir.
Here the problem is that the
Sir,
airway is blocked. What will you
sir,
do?
can we use bougie? Sir, can we use bougie at that time?
Bougie, you have failed with bougie. You have failed to bougie will only pass if you are able to see anything. If you are not able to see
Mm-hmm.
anything, then what will you do? Okay. So in this scenario, actually, the problem, what is the problem? The problem is the obstruction. Okay. So you don't have any other option. You have two, three options because now most probably it is the compression. Okay. So what you can do, there is, you have, all of you have heard salic maneuver, but I will ask you, what is reverse salic maneuver?
We'll pull the mask up.
You not pull the mask up. Who answered? It's not the mask. Mass. Oh, I'm sorry. If you said mass, yes, it is the answer. Okay. You will lift the mass. You will lift the mass. This is one option. Other option, maybe you will try lateral. One option number two, lateral. Maybe if you try to tilt the patient a little lateral, maybe the obstruction will be relieved and you are able to do it. Then, of course, to start with, you will never proceed this case without having ENT surgeon with you. So that is the answer, that you should have bronchoscope, rigid or which should be there, rigid or soft.
Rigid.
Very good. Okay. So that is the answer. So if you are not able to intubate, if you are not able to ventilate, in other cases, your answer is cricothyrotomy. Okay. Cricothyrotomy or like a scalpel percutaneous tracheostomy. Okay. So that will be the thing which you will be doing. Needle, not scalpel. The needle cricothyrotomy and converted into or percutaneous tracheostomy. Okay. So that will be the answer in this scenario. This is a special scenario, but you can you may be asked this scenario in thyroid case. Okay. So yes, thank you very much. This is the answer. So this is, I'm just giving you a real time scenario because other things are fine. You will do the jaw thrust. You will do the chin lift. You will try to change the laryngoscope. These all you know. You will change the laryngoscope. You will change the position. You will. So this is something which is not clearly written in the books. So I just try to start my discussion with that one. Okay. So ramp position, rapid airway management position. For many years, I used to think that it is the virtual English word ramp position. But actually, after many years, I came to know that this is not ramp only. This is rapid airway management position. Okay. So this is another thing you should be doing in a rescue situation. A special scenario and awake the patient. Of course, you will try to awaken the patient. You will try to have the front of neck access, as I told you. So these are the basic thing you should be knowing. Change the blade, change the like position, try to facilitate with either with video laryngoscope or glidoscope or things like that. So these are the different answers to your question. Use of bougie, use of stylet, but like these are the things which you will be doing it, except in this scenario specifically. Yes, Noman, what do you want to ask?
Sir, I just want to ask that, sir, there is one technique, the reverse endotracheal intubation. So that is done by us, or we have to take support from ENT specialist
Actually, that is
in
called as
this case?
retrograde. That is called as retrograde intubation. Okay.
Yes, sir.
Retrograde intubation, you will just pass the cricothyrotomy and you will move it up and then you will try to do it. It is actually the percutaneous procedures or needle procedures. It's in the answer you will speak like that, but of course, practically, how many people are expert in doing tracheostomy? Okay, I'm doing in 19 years. I have never
بحاول بس
faced.
بدل انت الوقت ما يريح مني في ربع ساعة 10 دقائق من المحاضرة. المحاضرة تقدم فيها.
Okay, so I hope understand, Oman. So it's ideally you can say that you always, whenever you are dealing anticipated, this will be for an unanticipated. Okay, because anticipated, you will never proceed without all the precautions. This is, for example, you had an emergency case and now unanticipatedly you face this. Okay, so anticipated difficult intubation, you will proceed, prepare for everything in the world, whatever you have, like LMA, iGel, airway, nasopharyngeal airway, a glidoscope, video laryngoscope, McGrath, whatever you have. Okay, this McCoy laryngoscope, difficult, different size endotracheal tubes. Okay, even the surgeon will be ready for tracheostomy, and you should have all the things. Okay, so this is for anticipated. And actually, these questions, they are coming in unanticipated. Okay. Because sometimes you did not anticipate and you find to have this one. So another important thing which you should be knowing, it's with reference to maternal patient. Okay. So maternal patient, there is a little bit different like thing that you here, because in other cases you will awaken the patient. Okay, but in maternal patient there are some you have to look at the fetal distress. Okay, if there is no fetal distress, you will awaken the patient, but if there is fetal distress, then you have to proceed with the surgery. Okay, if maybe you will try to put igel, or you will try to use intubating LMA. Okay, and you will proceed with the case. You will find very beautiful points written in the DAS guidelines, that if you are not able to vent, sorry, the fetal distress, according to fetal, there are 3 4 things you can have a look. I will try to show you if I get the time. Okay, otherwise everything is there in the articles folder. You can find everything. So I just want to give you an idea how to proceed with it. Okay, different, if you are not able to ventilate the patient, there will be certain factors which will predispose the patient. Okay, like for example, just a second here. Yes, see, this is for difficult mask ventilation. Male gender, mask seal, Malam patti 3 or 4, mandibular protrusion, age, snoring. Okay, so there are different formula: obese, bearded, edentulous, snoring, elderly. There is some other formulas as well you will find. But you try not to memorize everything. Just try to have a basic concept about it. Okay, because sometimes it's not that you want to tell 10 things. Try to have a logic. If you memorize few important things and forget some less important thing, there will be no problem. But if you try to memorize everything and you are not able to, everyone will be doing encouraging to have mnemonics. But remember one thing, the only problem with mnemonics is that sometimes you don't recall the mnemonic. Number one. Number two, in the mnemonic, it's not necessarily the important things are presented first. So in the exam, this is the one of the reason for failure, that you are not able to reproduce the mnemonic in a proper way, and you are telling the less important thing and you are forgetting the more important thing. So this is everything should have some understanding. Okay, so this is, I think, if I'm not wrong, this is the scenario for it, that you are difficult mass ventilation, optimize patient position, check that. Yes, depth of anesthesia is very important. So that's why I will suggest you, I had uttered this word in my some previous discussions as well, that RAM position, people, it is recommended. Why, like it recommended for obese patient or pregnant patient? But I tell you something, there are so many advantages with RAM position, that actually not specifically exactly RAM position, but I try to elevate the head side a little bit in almost all patients, and try to bring the head of the patient just next to your belly. Okay, so that you can fix the patient head with your belly and your both hands will be free. If you just imagine, if the patient's head is away, actually one hand is usually lost in stabilizing the head. So this thing you can easily bypass If you bring the patient near to you, like head should be at the level of your umbilicus, and you fix the patient's head with it, then the laryngoscopy and intubation will become very easy. Okay, so this is something like, of course, in the books you will write here, you see 2% forehand technique and this and that. So two people will be doing the mask ventilation and two people will be holding the mask. Sorry, two hands will be holding the mask and two people will be trying to ventilate the patient. Practically speaking, if you
كويس
if
ها
you if you remove the obstruction, then it will become very easy for you to manage. Even I will suggest you that if you have a good ventilator, you can put the patient on pressure control. I never, maybe many, for since many years, I have never ventilated the patient with my hand. Never, maybe many years. Okay, I just put the patient, I hold the mask tightly, beautifully, and then put the patient on ventilator with the pressure control mode. Okay. So the advantage will be, because when you are ventilating by hand, the problem is that either you are hyperventilating or hypoventilating. Either you are giving high pressures, which can predispose to the aspiration. So if you are able to have a good capnography, then you can see the patient in a good shape. You can monitor the tidal volume, you can monitor the airway pressures, so everything is in your hand. Okay, but of course, if you don't have that facility, the ventilators are volume control will not be a good choice actually, because volume control, if you put a slightly higher volume, maybe the airway pressures will become more very high. So it is specific with the ventilators which have pressure control mode. It will be better in if you want to use the normal traditional ventilators which are freely available, then it is better that you to try to keep a little lesser airway tidal volume. Okay, so this is my advice for it. So because again I'm telling you that my focus is not to tell you the things which you know. Okay, all people know about DAS guidelines, but how to interpret it all, because in the exam they will give you a scenario, you are doing this had been done, what will you do? So not if you have the concept, you don't need to cram the gas the gas guidelines. Otherwise it will be difficult for you. Okay, so because if you have the concept, then you can handle any question, whether it is MCQ, whether it is written, whether it is being asked in the oral exam. Okay, so I hope you are with me. You are understanding what I am trying to tell. I'm not saying that
Yes, sir.
you will not be able to ventilate, Imran. But the thing is that I tell you something. Forget about what the senior around you is telling you. I'm not saying that bypass them. Of course, when in the Rome, do as the Romans do. Whenever you get a chance, try to do something. Okay, because remember one thing. No, it is not necessarily that whatever is being told by your senior, he will never tell you intentionally a wrong thing, but he may be wrong. Okay, so if you close the door, and I daily I try to learn daily. Believe me, the day you close the door of learning, that will be your decline. And believe me, I tell you something. Some people, a number of my friends, they used to say, "What are you doing? You are trying to have class daily. You are wasting your time. Nobody is listening to you, and like you will be tired." I said, "Well, remember one thing. I take it as a worship. I'm trying to help my specialty. That's why I don't care, because I don't have any other interest. Don't think that people on in this group, I have nothing. I have no interest, believe me. Yes, if you will learn, I will be very happy. And remember another thing, the best way to learn is to teach. If you try to grab whatever you have learned and try to tell other person, you will never forget. I have never read anything since last 6 years. Appeared in the last international exam way back in 2017, and I am whatever I recall. Only the blessing are you people who are here to listen to me, because I will tell you something, that if you want that you don't forget what you are learning, and this message is for the people who have already passed the exam. After some times, believe me, the embarrassment time will start. If someone asks you a question and you have don't remember, you know what will happen? He will come out and say he doesn't know anything. And this is a reality. That's what we used to do. That if we ask any or senior around us and he doesn't know, we used to think how he has passed the exam. He doesn't know. But the reality is that he has passed the exam, but now he doesn't care, so he has forgotten. So actually, the best thing about teaching is that you will not forget what you have hard earned, and you are dealing with someone's precious family member. So you should be updated. You should know, because any other specialty, maybe the result will not come immediately. But anesthesia, if you are not up to date and you are not in par with the recent developments, you will be lag behind. Okay, so that's you will expect that your family member gets the best care. So I think the same is true for others. Okay, so I will come back to what I was telling you. These are the questions. These questions answer you will find Cormack and Lihan classification, and yes. So some points about airway assessment. Usually there are tests about it: mouth opening, jaw protrusion. There is Lemon law. There is TM. This one, this distances. Okay, mento higher distance and sternomental distance. These distances, of course, you should be knowing what is their sensitivity and specificity. Okay, I don't remember these things, but you should be, because in MCQ they will be asking you about the sensitivity, how you interpret it. So you should have a like look, evaluate. Okay, lemon eye, it will come here. So you should have it. After that, after the clinical examination, there will be some tests. Okay, either it will be hi-fi radiological studies like CT scan or MRI, and you should have, whenever you are expecting any tumor or any thyroid or anything which can have deviation, like patient had radiation, patient has a large thyroid, patient had some any airway surgery before. Okay, so in that case you cannot proceed like that. You have to do the the investigation through which your aim is to see number three things you will see. You will see that the trachea is in the center or deviated, because that can create problem for you. You will see the patency of the airway. Okay, then you will see any signs of compression. So in addition and then another important thing with reference to thyroid is that the extent, if it is going retrosternal or not, because if it is retrosternal, that can create problem to you, and that can, of course, the surgery will be more complicated if it is retrosternal. And of course, now everyone knows about the situation. I will give you an example that recently I was anesthetizing a case for thyroid, and unfortunately maybe it was not properly seen by the surgeon who was trying to operate. And in the morning I said to him, I need blood, because I had seen the MRI report and the thyroid had engulfing the common carotid. Okay, so they were going towards that area. So he doesn't know about it. And can you believe this? Can you believe this? That case was cancelled, in the sense that they only did the tracheostomy and that's it, because that was a resectable tumor. So you will find these situations as well. So actually, you can help yourself, you can help the patient, and you can even help the surgeon. Because sometimes surgeons, of course, this will never happen frequently, but infrequently you will see such things happening. Okay, so you always remember one thing. This is a message, that always ask the surgeon, what are you expecting? What is your plan? This make a habit, that what is his plan, what he wants to do, what he is expecting. This makes this thing habit for you, especially in the cases which has some complications, like any bleeding, chances of bleeding, or any involvement in the airway. Okay, so other tests are the same, like cervical spine x-ray, they have written here. Okay, so these are the things which you should be interpreting whenever you are doing it. And nasal endoscopy, before used to be indirect laryngoscopy. Okay, but now it is replaced by nasal endoscopy. But nasal endoscopy, they will see the vocal cords. Okay, and they can, in that one, they can also see the, like, any problem you can expect. Okay, and the other investigation written is about flow volume loops. So flow volume loops will tell you about the extent of the tumor, any obstruction, like intrinsic or extrinsic causes of stridor. Okay, so these are the things you should be knowing, that whenever you are evaluating a patient with difficult airway, only looking at the patient will not tell you everything. Okay, you have to think other things. If you are not able to interpret these things, maybe your the CN and your management will be wrong. Okay, so this is okay. So whenever you are evaluating a patient, these are the questions you should ask. Even the patient, the people who are going for TOEIC, OSCE exam, they always ask what we should do. Even if you are examining the patient, you can ask this question. When you are examining the neck, you can tell if you have any pain. If you are, when you are asking to open the mouth, you can say if you have any pain here. So mouth opening will be related to TM joint pain. Okay. If the patient has TM joint pain, he will not be able to open the mouth easily. He will have pain. Or if there is ankylosis, for example. Okay. So loose tooth, artificial tooth, snoring, nasal blockade, hoarseness. Okay. Because there are dentures which are fixed. Fixed dentures will not create a problem to you. But number of time you will find that the teeth are very good, but actually they are the dentures, the artificial denture which are removable. Okay. So these, and nasal blockade, hoarseness. Nasal blockade and snoring and hoarseness with more important with reference to mask ventilation and with reference to if you are trying to have nasal intubation. Let me see what comments are coming here. Also in spontaneous ventilation, I use pressure. Okay. Pressure. Okay. Okay. Fine. Yes, Noman.
Sir, because sir, if removable dentures are there, sir, it will make the anatomy of the airway good. So, sir, is it possible that to ventilate the patient before intubation, we can keep the dentures there, and while
It's a
intubating, we remove the denture?
it's a beautiful idea, but actually, the problem is that usually the routine is that we remove it because it's a medical legal issue as well. If you lost them, for example, so it's a, like there are other things you have to be careful about it. And for example, of course, usually it is true for full denture. Okay, if they are small, they can still, it can fall down. Okay,
Okay,
because
sir.
when you are manipulating the patient's airway, you don't know what's happening. Okay, so for example, if it is one or
Mm-hmm.
two tooth, it can fall down very easily. Okay, so then you
Yes,
will
sir.
have a foreign body. So okay, so you should be thinking about it. Okay. So Malam Patti
Okay,
classification,
sir.
as I was telling you, thyromental distance, steromental. I again tell you something because my aim was to finish the discussion in 30 minutes. Unfortunately, sometime if you try to squeeze the things, you take more time. These things which are written and clearly mentioned, I'm just trying to skip. I will send this document to you and you can have a look. Okay. With reference to OSA, of course, if you find more factors, then you will send the patient for OSA studies, flow volume loop, ABGs. This is will be extra thing with reference to airway, of course, but it is related to other things more than this one, airway. Okay, but still you can have some signs or something which you should be knowing about it. Okay, so uh, I think now there are DAS guidelines of 2020. So I think this one you should. I'm not sure what is the change has been done, but because the concept remains the same and practically when we become in practice, actually we are not seeing these things. Can anyone tell any change from the previous one? If someone knows about it, please do tell me. If anyone knows that any change which was occurred in 2020 DAS guidelines which were not there in 2015. Okay. Anyways, if anyone even later on, if you come to know, do share with me. Okay. And so with reference to extubation, actually there are 2 3 algorithms which should be knowing. One is the extubation algorithm, and then another one is with reference to tracheostomy. Okay. So there is a algorithm for block tracheostomy. So maybe we will do it some other time. Because my aim was to just give you an idea about how to, yes, some words about rapid sequence induction and modified rapid sequence induction. Okay, so there is a little bit different with it. In rapid sequence induction, you are determining the doses and you are doing it in, and I still remember a number of time when we used to ask because in emergency we always used to do rapid sequence induction. Never tell in difficult airway. In difficult airway, you will never do rapid sequence induction in the exam. Practically, we always do like this. But in the exam, never tell this. In exam, whenever the question is asking this, always say awake fiber optic. Even though you will say that hardly you will do awake fiber optic ever unless you are dealing with such cases frequently. But overall, not everyone will be doing awake fiber optic frequently. But still, in the exam, if they create a scenario in which you have anticipated difficult airway, never tell rapid sequence reduction. This is my message to you. Okay. So you will only do it with reference to aspiration risk. Otherwise, if you say that you have difficult airway suspected and you try to do it like, the conditions they are reading, gastric emptying delay, gastroesophageal reflux disease, or emergency trauma. Okay. So this is I wanted to tell you with reference to rapid sequence and modified rapid sequence induction. You will this will help you in answering the question exactly, even in the talks, because OSCE they ask these questions. So you see, these are the mnemonics you can find here: soap me, suction, oxygen. Okay. Laryngoscope. These are the common things which you do in any other patient as well. Okay. Okay. Anyways, thank you. If you can share, Imran, the latest airway guidelines, because I don't remember any change about it. Okay. So in modified, you are giving the titrated doses. Usually, you are using rocuronium, and so that you can reverse it with the sugammadex if you want. Okay. Salic maneuvers. I told you this is an important question which they ask in their OSCE, that how will you tell that this is 1 kg 10 Newton, and how will you tell that it is 30 Newton? So because 10 Newton is before the loss of consciousness, and when loss of consciousness has occurred, then you will make it 30 Newton and you will remove it. Once you confirm the endotracheal tube, the cuff has been inflated, then you will remove it. So actually, if you press the weight machine and the 1 kg weight is coming, that pressure is exactly 10 Newton. And if you press the weight machine in with the pressure and the weight goes to 3 kg, that is 30 Newton. Okay. But practically, how will you do it? I don't know. Because actually, you will don't tell anyone, but I never do it. I hate this Salic maneuver, and I never do it. If you make ramp position, okay, actually you never need it. But again, medical legally, if someone does not do Salic maneuver and it is documented that he does not do Salic maneuver and aspiration occurs, actually, according to some people, some of my friends told me that even in the UK guidelines, though, and there is always a debate about cricoid pressure, because actually, practically speaking, what I see in my early part of training, that actually that intubation become difficult because of not the concept of Salic maneuver. The problem is that it is not being done by you yourself. It is being done by the other person. Okay. So the problem is not the concept of Salic maneuver, because the concept of Salic maneuver is that you are pressing the cricoid cartilage with the esophagus. Okay. But problem is that, unfortunately, try to see your own anatomy. You will not be able to identify the structures. The problem is that the conduct is usually it is wrong. Usually it is wrong, because you will be asked in your OSCE that how will you explain to your technician anesthesia, because usually it will be done by you, either your colleague who is standing with you or with the anesthesia technician. So how will you explain? So actually this is the problem. Again, this is a practical thing. Please, you never quote this thing in exam that Dr. Zishan told he will kill me, and you will be killed and you will be responsible. I myself will say that I never told you to tell in the exam. But practically, yes, practically speaking, I tell you that I love RAM position, and RAM position actually decrease the chances of aspiration, rapid regurg, because the patient had it has to go up uphill. Okay. Because if you are making the head side up, actually it needs creation of a lot of pressure in the gastric pressure to have the regurg. But if, of course, still it can happen. I'm lucky that I did not face it, but it doesn't mean that you don't have. Then another, this burp maneuver, this backward, upward, rightward pressure to see. Again, this is again being done by the person who is standing with you, and unfortunately sometimes they are not able to do it in a nice way. Okay. What are the components of difficult airway management trolley? You will see actually, because I'm in these few days, I'm just trying to give you a basic concept of anesthesia. We started from preoperative anesthesia and we just move on. Okay. They can ask you how to do the pre-oxygenation. Okay. So you should be knowing that how to achieve it and how to do it. Like how to confirm it that you have already done it, and you will see the end-tidal oxygen and tidal nitrogen if you have the agent analyzer. Okay. So these are some theoretical questions which are written here. Retrograde intubation. Someone was asking about retrograde intubation. Okay. So it is the retrograde intubation. By the way, there is another technique which is called as blind nasal. And I have seen during my training a number of people doing it. They used to listen the sound. They used to do it in spontaneous ventilation, deepen the patient with an inhalational agent, and then they do it. I have seen many old people doing it, and I'm afraid out. I don't know how they do it, because there is no person now who is practically doing the blind nasal intubation in the facial-maxillary cases. Okay, the trauma like in which the mouth is not opening and they are doing it. And there I have seen actually during my training there was one anesthetist he used to do, because he was doing it for last 30 years. So he was expert and he was an authority. But I remember he used to have a silence and he used to listen to the sound of the air coming, and he used to pass, and his success was almost 100%. Anyways, so this is something practical things. Okay. So I think I will stop here, because I will not be able to finish in one setting. I think we will continue this discussion tomorrow, inshallah, to just see. Yes, pressing tip of nose is good, but again, I tell you something. There is no way. Maybe if you touch someone who is saying you are hurting me, maybe someone has more threshold. So unfortunately, it cannot be objective. It is subjective. Okay. So how maybe if you are very huge, big size, and an anesthesia technician is with you, even if it is touching, maybe the pressure is too much. So anyways, this is something. I tell you, okay. Okay. Anyways, so I will stop here, because I think I will not be able to have honesty with this topic. I need some more time. Anyways, thanks a lot, all of you, for coming. And we will continue, inshallah, the airway management part 2 for tomorrow, same time. Assalamu alaikum.